difficult tracheal intubation accounts for 17% of respiratory related injuries, and 28% of anesthesia related deaths are due to inability to ventilate or inability to intubate. So assessing the airway and planning your strategy is most important in our field. So failure to assess the difficulties in airway management and failure to incorporate your findings in your strategy contributes to the poor outcome. There are many airway assessment tools, but the perfect assessment tool does not exist, and still unanticipated difficulty will occur. Using multiple tests rather than using a single test is better predictor for predicting the difficult airway, and assessing the airway at extubation is most important while handling the difficult airway. So what do you mean by difficult airway? It is defined as a clinical situation that a conventionally trained anesthesiologist experience failure to mask ventilate or failure to intubate or both. So before proceeding for any kind of anesthesia, one should ask this question to ourselves. Will I able to mask ventilate the patient? Will I able to perform the laryngoscopy? Will I able to intubate the patient? If I predict difficulty, should I secure airway awake? Can I assess the cricothyroid membrane if needed? And how will the airway behave at extubation? And if you have answer of these questions, airway related morbidity will definitely minimized. So coming to the assessment, we do airway assessment by clinical history, physical examination, and using airway assessment indices, radiological indices, and NAS endoscopy. So we'll go quickly through this. In clinical history, always ask for a previous airway management, whether it was easy or difficult, whether the patient has received any airway alert card, and you should keep proper record if you encounter any difficult airway for your benefits of few colleagues. History of chronic diseases like rheumatoid arthritis, ankylosing spondylitis, diabetes, where the joint movement is restricted, history of rare syndrome, history of recent respiratory infection, where the possibility of laryngospasm, bronchospasm can occur after the airway handling, history of snoring, OSA, daytime somnolence in case of obese patient, history of hoarseness voice, any voice change or ability to lie flat, history of facial trauma or any swelling over the face. These are the important histories. Location of airway management is most important. It is found that in emergency department and in ICU, the incidence of difficult airway is 10% more than the operation theatre. So coming to the physical examination, obesity, prominent chest, breast, beards, dental condition like edentulous, gaps in between the teeth, single incisor, mouth opening. If it is less than 3 cm, difficult laryngoscopy can be predicted. But some VL scope blades can be easily passed between 1.8 to 2 cm also. So moving to the indices, there are many indices mentioned in the literature, but it is difficult to use all of them. And here we'll see few of them which can be easily used in our day-to-day practice. So everybody must be knowing, this is just quick recap. MMC grading, modified Mallampatti grading, grade 3 and 4 contributes to the difficult laryngoscopy. Then thyromental distance and sternomental distance. It is measured in head extended position. TMD less than 6.5 and SMD less than 12.5 can contribute to the difficult laryngoscopy. This is how the distance measured. You should always measure the distance by measuring tape or ruler. So coming to the ratio of height to thyromental distance. It is a better predictor than SMD or TMD. RSTMD more than 23.5 is considered as a predictor of difficult laryngoscopy. Canel et al. Did a comparative study between MMT, upper lip bite test, TMD and RSTMD and found that RSTMD is a better predictor than all these indices. So coming to the ratio of neck circumferences to the TMD, it is also a better predictor in obese as well as non-obese patients, and ratio more than 5 is considered as a predictor of difficult laryngoscopy. Jaw protrusion and upper lip bite test both assess the mobility of TM joint and prognathic, and it gives idea about the prominence of maxillary teeth. So class 3 and 4 contributes to the difficult laryngoscopy. Coming to the neck movement, ability to achieve the sniffing position. What is sniffing position? It is a flexion at the cervical spine and extension at the atlanto-occipital joint. And maximum is possible, 35-degree extension is possible at AO joint. Everyone must be knowing of warning sign of delicans. Coming to the group indices, we have finished individual indices, group indices. 3-3-2 rule, everyone knows this. Then Lemon score, it is actually a mnemonic. L stand for look externally for facial trauma, large incisor, beard, mustache, large tongue. E is evaluate 3-3-2 rule. M is Malampatti classification. O stand for obstruction, any obstruction present in the upper airway. And N stand for neck mobility. Second is Shaghai and Safai score. It assesses the 6 factor: weight, tongue protrusion, mouth opening, upper incisor length, MPC scoring, head extension. This is simple head extension, not sniffing position. And any 3 indices are present, contributes to the prolonged laryngoscopy. Coming to the Wilson scoring, it assesses 5 factors and each factor carries score 0 to 2. Weight, suppose it is less than 80, it's 0, 80 to 100 is 1, more than 100 is 2. Like this scoring is given, and if score is less than 5, easy laryngoscopy, 6 to 7, moderately difficult, more than 7 is severely difficult. Coming to the radiological indices, X-ray, neck AP lateral gives an idea about the difficult intubation. Reduction in the space less than 5 cm from the C1 spinous process to the occiput in a neutral head position in a lateral X-ray contributes to the difficult laryngoscopy. It also gives idea about any foreign body present in the upper airway. Also it gives idea about tracheal compression or deviation. X-ray PNS can give idea about the facial bone fracture. Coming to the USG of upper airway, we are going to have a separate hands-on session on this. It is a newer advantage. We do assess airway while during the our technique, the intubation and all, to assess whether the tube is really inside the trachea or not. USG can give idea about the tongue thickness, pretracheal fat at the vocal cord, hyoid bone visualization. It also gives idea while performing the front of neck axis whether large vasculature is present in the vicinity of our incision. It also gives idea about the identifies cricothyroid membrane, cricoid cartilage and thyroid cartilage. So this is the sagittal view. Coming to the CT MRI, it is also helpful identifying the severity and stenosis of tracheal stenosis, and it can give better idea about subglottic and mediastinal extension of any mass. Coming to the NACE endoscopy, this is a newer technique we do use. It can be used when you predict a difficulty in airway management. So can be done in a OPD basis or in operation theatre before proceeding for the anesthesia. It can be done with flexible as well as rigid nasal endoscope. You can use flexible endoscope through the nostril and rigid endoscope through the oral cavity. And after doing NACE endoscopy, you can plan your strategy whether to go ahead with direct laryngoscopy or with flexible bronchoscopy or direct surgical airway access. This is how you assess the airway, and you should plan your strategy when you are handling the difficult airway. This is quick recap of difficult airway guideline. If you are predicting a difficulty, you should be ready with your plan A, B, C and D. What is A? Face mask, ventilation and intubate. If succeed, proceed for the surgery. If failed intubation, then move to the plan B, that is use of supraglottic airway devices. Second generation is preferred. If oxygenation is maintained, then stop and think whether to go ahead with the surgery, whether to awake the patient, whether to secure the airway through the supraglottic airway device, intubate through the supraglottic airway devices, or whether to proceed for tracheostomy or cricothyroidotomy. But even with the supraglottic airway devices, oxygenation is not maintained, move to plan C. That is, again, attempt face mask ventilation, use adjuvant like oropharyngeal airway, use 2% face mask ventilation technique. If you succeed, wake up the patient. But if you fail, then declare CICO situation and go for a cricothyroidotomy. So this is how you declare CICO situation. Always maintain passive oxygenation with 100% oxygen and do scalpel cricothyroidotomy. We'll be having this separate session today. So moving to the airway consideration in ANC patients. Why to bother with physiological changes of pregnancy? Because in pregnancy, diaphragm rises up to 4 centimeter and it can give rise to less negative intrathoracic pressure and decreased FRC and RV. Lung compliance is often poor, but the movement of diaphragm and intrathoracic muscle motion is normal. There is significant weight gain and PIH related airway changes is bothersome. There is increased risk aspiration pneumonitis in ANC patient because GE junction barrier pressure is always decreased. There is cephaloid movement of stomach and pylorus. pH of gastric content is less than 2.5 because of placental gastrin. Gastric volume at any given time is more than 25 ml. And decreased lower esophageal sphincter tone, increased pressure and delayed gastric emptying can contribute to the increased risk of aspirations. So why airway management is difficult? Because weight gain is more than 20 kg during the third trimester. Large breast contributes to the difficult laryngoscopy. Upper airway edema and mucosal congestion occurs during the labor. There is reduced FRC and RV and increased oxygen consumption allows less apneic period during the ventilation and laryngoscopy. And there is increased risk of regurgitation and aspiration and urgency of operative procedure as compared to non-pregnant. So managing obstetric airway, always assess the airway before proceeding for any anesthesia. Lemon score is very useful in pregnant patient. Alternative airway equipment should be kept ready, such as Vaca blade, stilette, stubby handle, laryngoscope, polio blade, laryngoscope, etc. But if it is not available and large breast causing difficulty in laryngoscopy, then introduce the blade first like a tongue depressor and then reattach the handle and do the laryngoscopy. Prosil LMA, intubating LMA, combative can be kept ready. Anti-aspiration prophylaxis is must. Positioning during the intubation is very much important. You should give a shoulder pillow over the shoulder so that the large breast can be fall away from the neck and chin. Cricoid pressure is must. So this is how the position is given. First is wrong, second the shoulder pillow is given over, under the shoulder so that the breast is away from the chin and neck. So these are the physiological changes we gone through. So coming to the safe obstetric general anesthesia algorithm 1. So pre-theatre assessment is very, very important. Always assess the airway, fasting status, anti-acid prophylaxis, intrauterine fetal resuscitation if required. Always follow the WHO checklist. Identify the help and equipment before proceeding for the anesthesia and always discuss your plan with your fellow surgeon. So pre-oxygenation is must. Then face mask ventilation with less pressure, that is up to 20 centimeter of water. Then after face mask ventilation, consider first attempt of laryngoscopy. If it is succeed, proceed with the surgery. But you find it difficult, then release the cricoid pressure, maneuver larynx externally, use stilette and intubate. If it is succeed, proceed for the surgery. But if fails, continue with the face mask ventilation and do second attempt of intubation with different laryngoscope and releasing cricoid pressure. But still it fails, then third laryngoscopy should be done by expert colleague only. And if it fails, then follow the algorithm 2. So 3 attempts of intubation fails, follow the algorithm 3. 2, use supraglottic airway device, second generation is preferred, and ventilate the patient. If oxygenation is adequate, then stop and think whether to proceed with the surgery or awaken the patient. But if with supraglottic airway devices still oxygenation is not possible, then follow the algorithm 3, that is can't ventilate, can't oxygenate. In this, declare the emergency situation in theatre, restore the oxygenation by giving passive oxygenation. It is essential to perform the front of neck axis if possible. But if it is not possible, then emergency maternal advanced life support should be initiated and pre-mortem caesarean section should be performed. So summarizing all it together, each pregnant woman must be evaluated for difficult airway. Despite airway evaluation, 50% difficult airway cases remain unanticipated. Anesthesiologists must have planned anticipated as well as unanticipated difficult airway. Rapid sequence intubation is standard during the pregnancy. Pre-oxygenation is must, and manipulation of airway should be minimum to avoid the bleeding and upper airway trauma. So coming to the pediatric airway consideration. So the pediatric airway is smaller in diameter and shorter in length. They have relatively large tongue in the oropharynx. The larynx in infant is located more anteriorly. The epiglottis in infants is usually long, floppy and narrow. In children younger than 10 years of age, the narrowest portion of the airway is below the glottic opening, that is at cricoid level. And all these factors can contribute to the easy desaturation as compared to the adult. So these are the changes we have seen. So pediatric algorithm, it is little bit different. So plan A is always back mask ventilation with or without adjuvant, that is oropharyngeal airway. If you succeed, intubate. If intubation is failed, then go to plan B, that is again back mask ventilation first with the adjuvant and then use laryngeal mask. If it is failed, call for help early. If can't intubate, can't oxygenate situation arise, then do either needle cricothyroidotomy, Seldinger cricothyroidotomy or surgical airway access. So this is a quick recap of can't intubate, can't ventilate situation in paralyzed children. So failed intubation or inadequate ventilation, use 100% oxygenation with nasal cannula and call for help early. Then step A is continue the oxygenation with supraglottic airway devices and try to ventilate the patient. If ventilation is possible and saturation is above 80%, then try to wake up the patient. But if ventilation is not proper and saturation is falling less than 80% and there is a bradycardia, then go to step C, that is airway rescue technique for CICO. If ENT help is available, perform surgical tracheostomy or do rigid bronchoscopy and ventilate with jet ventilation. But if ENT assistant is not available, then perform cannula cricothyroidotomy and start jet ventilation. If it is succeed, continue ventilation until the patient wakes or until the definitive airway is secured. But if it fails, then perform the surgical cricothyroidotomy. Then to summarize, it is important to highlight the need for basic intervention and call for help early in the pediatric airway. All plans should be well defined, well informed to the team, and location and availability of the backup help is always confirmed. If the next step in procession is not able to perform, it is essential to go back to your previous step, which is work. That is, if bag mask ventilation is work, go back to bag mask ventilation. It is important to note that preparation and planning are the most important step in prevention of unanticipated difficult airway, and if it is anticipated difficult airway, expert help should be rapidly requested. Remember, difficulty in face mask ventilation is very unusual in pediatric patient, that is less than 0.2% as compared to adult. So if you are not able to ventilate with the bag mask, always confirm that head position is proper. If child is less than 2 years, you roll over shoulder. And if child is more than 2 years, neutral position. Correct size mask is always helpful. Then tight sealing should be there and depth of anesthesia is adequate. If these things are achieved, then face mask ventilation can be performed 100%. Then follow the difficult airway guideline. So take home message is failure to assess and identify predicted difficulty in airway and failure to incorporate your findings in your management gives poor outcome. Any single perfect assessment tool does not exist, so unanticipated difficulties still occurs. Use multiple tests rather using a single test when suspecting a difficult airway. And assessment of difficult airway at extubation is equally important, and plan your extubation strategy accordingly, and always follow the difficult airway guidelines. Thank you.